Senator Cassidy.
Hello, you all. I would say gentlemen, but you too, Dr. Bianchi. Thank y'all for being here. You probably know from previous kind of questionings, lines of questions, I've always been concerned about priorities and spending. And so just a couple of things as background. The societal cost of disease here, and you see that there's roughly, if this is disability life years adjusted, and for my colleagues who may not be familiar with this, just an amalgamation. If somebody has an illness, how much do we lose in terms of productivity with an element of death? And then here is just the mortality. And this is from 2015. The funding levels are from 2016. But we see as we look at societal cost of disease, there's roughly a correlation between how much it costs disease, how much it costs society, and the disability and the death rate it causes. I have two figures for obesity. One is how the CDC just says, okay, these are the folks who die, and this is everybody for whom obesity is listed on the coroner's report, knowing that obesity leads to a lot of other conditions that might be the primary cause of death, for example, heart disease. Can you hold up the other, please? Now, kind of my continued concern, and again, Senator Collins, you may, we hand it over there. Sure. Just to the side and don't block the camera because the camera will want to see their pretty faces. Hold it up higher, please. Higher. So here you see the NIH funding, and we see here is HIV, but obviously a lot for HIV. Here is diabetes. Societal cost, and although we spend a lot on diabetes, it is not as much. I'm struck, though, and what I want to emphasize is the obesity. Now, this scale can't do justice to how much of a difference it costs society in terms of societal cost of obesity relative to funding. So there's the NIH funding by disease. It's $965 million, even though it cost us $190 billion. Now, so again, it costs society, obesity, $190 billion, but we're spending $965 million. The size of the bubble represents how much money we are spending upon it. And can you hold up the racial disparity issue? As some of you may know, I worked in a public hospital in Louisiana with the uninsured for 35 years, and you can't help but notice that there is a racial difference in obesity. So if you look at race, any mention of obesity on the death certificate, African Americans, much higher rate of obesity. American Indian or Alaska Native, here's whites, here's Asian Pacific. I think if we put Samoans, though, it would bend up like that. So there are some clear racial disparities associated with obesity. So I guess my question is, and can you hold up that other one, not that one, but the other? Is it just a function of how we appropriate money? Because it does seem that obesity as a primary illness is underfunded relative to the societal cost. Again, $190 billion societal cost, $965 million, in contrast with some other diseases with far less societal cost, but far more NIH funding. Dr. Collins.
Well, Senator, it's nice to have another iteration of a conversation we've had over 2 or 3 years, and I appreciate your perspective on obesity, which I totally agree is an enormous public health challenge for our nation.
And by the way, can I just, for those who may not know, obesity is implicated in Alzheimer's, implicated in heart disease, implicated in cancer, implicated. So although it may not be primary, it is the match that starts the fire for a lot of other diseases. I'm sorry to interrupt.
No, that's quite all right. I think your point is taken. The question that we at NIH are always wrestling with, and you've seen the way we played this out in our strategic plan that we put forward a couple of years ago that tried to really articulate how we set priorities, is this balance between public health need and scientific opportunity. I think with obesity, we would all agree that the problem is a multifactorial one. That there are many aspects of this that relate to things that NIH probably can't control in terms of diet, lifestyle, even the built environment and so on. We are studying those things pretty intensively. In terms of interventions, though, to do something about this epidemic, which is a fairly recent one, it does not look as if a medical therapy is on the edge of happening. And so it's a bit of a different circumstance than, say, HIV/AIDS, where we have a clear path towards a vaccine.
If I may interrupt, Dr. Collins, in all due respect, In the past, you have told me, and I won't mention the institutes, but you've said, well, we don't really fund that because we're really not on the cusp of great advances. I go speak to the director and they say, without mentioning your name, and they say, oh, you got to be kidding. We got so much opportunity here. And that was kind of repeated several times. Now, and if I spoke to obesity researchers, they may start speaking about microbiomes and leptin and all this other stuff that, again, kind of quickly passes my level of knowledge. But it does seem to be self-fulfilling that if you say we're not going to fund it because we're not ready to go to prime time in our research, you never go to prime time in your research because you never have the requisite pre-funding.
I think we're ready to go to prime time and research with obesity. It's a question of where are the scientific opportunities. You mentioned the microbiome. That is certainly a very powerful one. Clearly learning things there that play out both in terms of obesity and diabetes, for which a big investment's being made. Although some of that research might not actually score as obesity. It might score as it's a diabetes project or it's a nutrition project. Some of this, therefore, is just the bookkeeping part. But I take your point. Again, I think this is something we worry about every day when we meet as institute directors around the table on Thursday morning. Are we setting our priorities properly? Your input's been very helpful in that regard.
And I would just suggest that we begin to focus more upon obesity, which seems to be an outlier in terms of lack of funding relative to societal cost. I now defer to whichever of my colleagues on the other side of the aisle is due.